Well, welcome back to the Eyecare Experts. Dr. Terrezza, Dr. Bell, and we have with us again Dr. Corredor for this segment. Different topic, I think a pretty hot topic, especially nowadays. We're talking about AI, specifically in eye care, optometry, ophthalmology. There's so many things that are coming out, so many things I think that, we go to all these conventions, we try to go to, whether it's See here or Seco there or Vision Expo, we're always having a class or a seminar or something with, AI and what it can offer and what it can do.
Absolutely. My last meeting that I went was Academy in Boston, and I want to say that it was heavily involved into classes on AI and how AI is coming to our world and what the good, the bad, and things that we can think about and make it better or try to avoid. So it was really interesting and very eye-opening to be in those classes.
Yeah, I just went to Vision Expo East in Orlando at the convention center, which, by the way, is fairly large. The Pensacola Convention Center holds 10,000 people, as opposed to the Orlando Convention Center, which holds 200,000.
Goodness.
Yeah, that's
So,
a whole city right there.
Yeah, it was crazy. And 40% of the meeting was devoted to AI and eye care. So it's definitely making an impact on the manufacturing processes, on the product, things on drugs, on practices, on diagnostics. Gosh, you name it, it's doing it.
Well, I know with some of the programs and software, ways to maybe enhance diagnostic accuracy for conditions that we see readily, whether it be glaucoma, macular degeneration, things like that. There's different AI programs that can be associated with some of our special equipment, some of our photos to help assess the condition, what stage is it at, what's the percentage that it's going to advance and all that stuff. And then also the other aspect is to help streamline administrative tasks, such as scheduling and coding and all that stuff. I know, talk a little bit, I think you're one of the first ones a couple years ago that went with the coding aspect as far as verbally translation. What'd you think and how'd that go?
I did. I got exposed to it in New York, and the system was called Sanoa, which is the Indian word for listen. And you paid per patient, so I bought it. I fell in love with it. And I don't like to write on charts. I like to interact with patients. And so the first 4 patients, I bought it, it came in, it got installed, and I did it. And my head technician, Erica, said to me, Dr. T, why don't you at least look over what this thing is putting in your records? And I thought, well, that's a good idea. So I printed them out and read them. And my first experience was this patient had come in with decreased vision in her left eye. And I had noticed a scar on her cornea, which is the front of the eye. And this thing had, what I said about it, it all put it in very accurately. It was 99-point-something% accurate on every word I said. Wow. I found no mistakes. And the only part that was the kicker was in the assessment. It said this patient has reduced acuity in that left eye because of the corneal scar. And I said, no, I didn't say that. I said that she had a corneal scar. The reason why she didn't have good vision in that eye was she was amblyopic, which is a completely different ballgame. And so then I start reading the other charts, and this thing was making conclusions without me. And it's not that I can't be replaced, but I have to be replaced accurately. So I stopped that. But there's newer models. I just got exposed 2 weeks ago, as I say, in Orlando, and they're much more refined now. They expect this next year. So in 2023, the software changed every 6 weeks. In 2025, it changed every 6 weeks. 2026, it's going to change every 4 weeks. Goodness. In 27, it's going to change every 3 weeks. And that's expected. That's a 25% logarithmic growth. That's crazy. And they'll get better and better. So I'm very excited about where it's going.
Well, to that point, I mean, I think some of the concerns, algorithmic biases, inconsistencies, maybe data privacy, security, those are things certainly we want to consider, with patient information, HIPAA and OSHA and all that stuff. We've got to be very cautious about, privacy and patient information.
Well, absolutely. I mean, the way that AI, obviously everybody pretty much get it now, is by feeding these systems tons of information, tons of data, pictures, you name it. And of course, that information is going to be out there for just about any system to learning. And if it's got protection by the law because it's medical stuff, then we don't know where this information or how they're going to use it other than just the system learning to give us information and help us out with diagnosis and treatment and the admin stuff. But
Yeah.
I think that for me, that's probably one of the biggest concerns because I don't want my information out there. Obviously, I want the provider to have access to the system, but then the system is open to everybody. And, HIPAA and all the other laws that we have, I don't think it has the full protection into that information yet. I'm sure it's going to change. I'm sure politicians will see it that, hey, we need to incorporate into the law what's coming up with AI.
No, I think all that is valid. I mean, I certainly, with technology, with advances, certainly there are concerns, especially in version 1 versus what version 10 is going to be. I guess in general, my thought is the more information I have, the better.
Absolutely.
Like when I'm doing an exam, text asks me, hey, do you want me to do this Optos or this OCT or this visual field? And most oftentimes I'll say yes, because that is information. I'd rather have that information and put that in there, and maybe it plays a key role, maybe it plays a minor role. But the more information, the better I can make the diagnosis, the treatment plan, and all that stuff. So for me, and this is just speaking for me, AI, I think I want to use it. I don't want that to be the end-all, be-all as far as maybe what I put on my assessment and plan. I don't want the AI to decide what I want to do for this patient. But I want to be able to maybe the AI says this, maybe it agrees with what I say, maybe it says this different, and if it says something different, why is it different? Maybe I should go look and compare and contrast, but at the end of the day, I still want to be making the calls, on the plans and the treatment options for the patients.
Well, this OCT plan that I looked at, they had fed in over 1 million OCTs on patients with various conditions. And this thing on its own, so there are two types of learning for the AI systems. One is supervised learning, which is kind of like what you get when you go to school. Teacher teaches you this way, you learn that way, and then you apply that way. That's the way I was trained in clinic.
Yeah.
And then there's unsupervised learning, where you expose the logarithm and the computer to a whole massive array of data, and it teaches itself the correlations and the causalities and so forth. So if you really want to innovate, you use the second type to do that, okay? And the fact is that on the OCTs that were read, that the Gemini algorithm was able to differentiate from merely optos, from photos of the eye, whether it was male or female, with 98% efficiency, as opposed to the best ophthalmologists or optometrists who did no better than chance at 50%. The other thing it could do, and this is an interesting study, done by PhD ODs, that is optometrists with a PhD in science, is that they looked at systems and were able to, what they called the mystery factor, was to determine 71% of the time they could predict an early Alzheimer's patient. And that field is now known as oculonomics, and I think it's going to gain steam. Now that has to be double-blind tested and all the scientific rigmarole that has to occur. But these are very exciting options because, again, the sooner you detect a disease, the better off the patient is.
No doubt, no doubt. Well, I've got a few questions from patients, so I just kind of ask that anybody can kind of answer and we can kind of discuss it. Is AI, and I guess this one's specific to Eyecare, is AI biased towards certain populations?
I don't know that it is. I don't know how it could be based on, what the system learned from, obviously if you can tell whether male or female, I don't know if the system can predict, what kind of ethnicity or race or whatever. So I don't know that.
That depends on the algorithm
Yeah, I think
that
it's
was
the
done.
I mean, I think what they're getting here is there are certain conditions that we know that maybe it's more prominent in a male versus a female, or maybe it's more prominent like macular degeneration.
Yeah.
Are they going to bias based on that? But like you said, I think that's all to do with the algorithm.
Yeah. I mean, if we fit in information, obviously as Hispanics and African Americans, we tend to have more glaucoma in our genes. But if we don't tell the system, hey, this is a Hispanic male, this is just the pictures and this is what the optic nerve looks like, can the system deduct that, oh, this guy is African American or Hispanic, so yeah, he's going to have a higher chance of
So
getting.
to
I
answer,
don't know it. I don't know.
yeah,
that,
I think the answer is if the AI is biased, it's not the AI is biased, it's the humans that put in the algorithm that
Right.
cause the
That
bias
cause
to
the
begin
bias,
with. I
right.
think is the answer. Yeah.
I agree with that. Yeah.
What are some of the biggest? Here's another question. What are some of the biggest barriers to adapting AI? Barriers, I guess.
wow.
Maybe day to day, or just as a practice or an office.
Well, people are very averse to change. So getting them to change like they were with computers or cell phones or anything else, particularly older individuals don't want to learn the newer techniques. And I think that's a bias in medicine where they don't want to do it. And the other thing is there was a study done at MIT where radiologists, so they fed the scans again into an unsupervised learning condition, and the AI was better by almost 11% than the radiologist diagnosing the disease. And so some of the docs would have it done like that by the condition, just look at the results and then write up the report and go. And they found that after 6 months of doing that, their ability to diagnose conditions without that had dropped significantly. And it took almost a year to get back to where they were, because it's like phone numbers.
You get used to it.
Yeah, you don't remember the phone numbers because you got it in your phone. You don't use it. So therefore, you are the limiting factor because you get dumber as a function of not making decisions and not using your brain.
No, I
And so
can see
that's
that.
another problem that.
Well,
we'll
I
have
will
to
say
deal with.
this, since we're on that topic now, that age and certainly just practice, and there is no one out there other, certainly Terrezza is the main one. If there's any equipment, any technology, he's the first one in line, certainly
I
trying
agree. He's
to
the one
try
that's
it
trying
or
to get us
assess
to
it
it,
or
too.
buy it. So there's
agree.
none of that in our practice as far as,
No.
hey, we're content with what we have. We don't want to learn anything new or new equipment.
No,
because
no.
even if we wanted that, he said that's not the way it's going to be.
It's like, yeah, I saw this. What do you think about this? So then we got to go back and research it, and then so. But we're fortunate that he's a driving force in our practice where he's like, this is the new technology. Why don't we look at it? And obviously we got to take into account cost and implementation. What is it going to take? Is it going to be a stop-in clinic to get this system online? But I say a good percentage of the time, he wins, and then we got to adapt to the
Well,
technology.
we didn't ask him when he purchased down in Orlando. That'd be a topic for another day to see
Yes.
what he purchased
Yeah,
when
I
he was
know, we
down
haven't
there for
asked
the
him
Vision
yet.
Expo. But no, I think that the reluctance to
I
change.
did purchase things.
What's that?
I did purchase things in
Okay.
Orlando.
All right, we'll talk about that another day. But certainly reluctance to change. Cost was another one as far as barriers. So and this is one. This may be a tough one. Will AI improve patient access to care? That's one to think about. That may be a.
I think it will. What do you think, Tim?
I'm convinced it will.
Yeah,
There's a new
I think
model in
it's gonna
Germany
improve.
that does it. They're going to have these little stations where you go in and it scans your retina and does this and does that. It's all free. And then when they find suspicious stuff, they'll tell you to go to the doctor. I think we'll get more of that.
So it'll be a great screening tool
Yeah,
to get.
yeah, as opposed to
people.
being afraid of it, it's going to crank up business like nobody's business. Because there's so much uncovered stuff out there. You guys know that when you come across
for sure,
patients,
for sure.
they come in for the little complaint, and it turns out, oh, wait a minute, you got this, this, and this, and things get crazy.
Well, I mean, we always encourage any patient, certainly to come in for an annual eye exam so we can assess the health and the vision and all that stuff in office. But we also are practical and understand that some patients maybe are non-mobile, maybe they're at home, maybe, they have issues where they can't get to the office for whatever that reason is. And maybe these screeners are
Yeah.
able to pick up something and say, hey, this is something that needs to be addressed, where that patient would be left and not be accessed or diagnosed.
Oh, absolutely.
I think the volume that thing will generate will be crazy, and everybody will be short of eye doctors.
But on the other hand, we're looking at AI to help us diagnose and treat things at a faster or maybe a more appropriate level. Like Dr. Bell was saying, we have these instruments that now can see things that way ahead of before they become a problem. And if we have some way to detect it, we're getting those patients in the door, but then what are we going to do with them? Okay. And if we don't have technology that helps us, this system saw that, but now we got to use the equipment that we have and our knowledge and our experiences to go, maybe what AI saw is a big deal, or maybe it's not, and then we got to deal with that. But I agree with you. I think the access to care is going to be more available. It's more expansive to a lot of people using the AI systems that are coming online.
Well, they just closed I forget the number of rural hospitals in the United States with the funding thing. That was a
funding,
tremendous error. And poor people are going to get and they're not necessarily poor because they're rural.
Yeah,
That's
it's
another thing. There's people with big farms and,
Sure.
and all kinds of economic assets, but they're on the short end of the stick.
Well, the tough part for that is, money or no money, poor or not, is these are probably hardworking individuals that can't travel 2 or 3 days or leave the farm for a week because they're working and taking care of things to go, 8 hours or 2 days away for an exam.
That's right.
It's just tough
Absolutely.
to do. But here's the last question, and we talked about this a little bit already, but how accurate are AI systems in detecting eye disease compared to human specialists?
I think that's disease specific, but I think AI has the upper hand on us as a human being because even though we have a great working tool in our heads, AI is capable of analyzing data and being able to look at things from all different perspectives in a much faster rate than what a human eye can do. I know when I was in the military, they were using AI systems to analyze all these pictures, and a lot of the times, all these pictures, a human being has to go, frame by frame or with a little scope looking at things, and AI can look at the big picture and immediately detect the one thing that is important for the intelligence community. And I think AI is going to do the same for us. We can look at pictures, we can maybe pick, oh yeah, it looks like a little retinal heme, that looks like maybe just mild diabetic stuff, but AI can probably see stuff at a more microscopic level that is going to be able to pinpoint us and direct us in a better direction for patient care.
Well, I think, and then back to what you were saying, even at Vision Expo and what you saw, I don't debate that AI's got a higher percentage of picking up and seeing things. I guess my only reluctance would be I would want to make sure the treatment plan that AI generates is the same plan that I abide by. And that's because things are not always black and white, right? We see patients every day, and maybe they have this, but based on this other outline criteria, we decide to do things maybe a little bit different. And
Very individualized. is
yes,
what you're
so
saying.
I wouldn't want it to be, hey, this is just what you should do,
Yeah.
10 out of 10, because, certainly with patients and certainly with pre-existing conditions and knowing what we know from doing this, all of us over 20 years, there's things that we've learned along the way. I mean, we learned in school the book smarts, but in practice in clinic every day, we've also learned that may be not what you apply 100% of the time.
The selling point on the AI in Orlando was that it would lower the error rate, and I like that.
Yeah.
And that comes out better for the patient, not just in detecting something, but you forgot to ask this question. This lady's on this drug. Now, I had a case just the other day, and the oncologist called me up, and I've never had a call from an oncologist. He said, hey, you put this patient on Restasis, a drug for dry eye, and I've got her on therapy for doing that's counterintuitive. It was suppressing her immune system when he's trying to crank it up.
Yeah.
So I apologize, but I didn't see that. She was on that drug. She didn't tell me, but he picked it up when she went back for her 2-week checkup with him.
Well, as y'all can tell, it's a hot topic. There's a lot to discuss. We're just, just kind of broaching the surface here. Certainly, years and years, there's going to be new things that come along. I think eventually we're all going to have AI incorporated to some extent, whether it's coding, whether it's helping with billing, whether it's assessment, diagnostic treatments. Certainly, I think in every field. Healthcare, military, I don't know if anybody will be exempt from AI helping at least some sort. But we appreciate you guys watching the podcast. Go to our website, TerrezzaOptical.com. Any topics, any questions, we appreciate you guys watching. Thank you very much.
Thank you.